question into the box if you're left, and try to make the questions more general and then specific. Okay. And we're just going to go ahead and I think start or yeah. Okay. So I just want to introduce Dr. Shree Venkat. So last year we didn't have anybody from radiology or radiation oncology or surgery here. So this year that was our feedback, that we want to hear more about the other doctors that treat sarcomas besides just medical oncologists. So I've had the privilege to be working with Dr. Venkat since I joined Miami in February, and it's been fabulous to be able to work with her. She's an interventional radiologist. So that means that she went to medical school at Michigan, and then she did residency and a radiology, and then she had to take an extra fellowship in interventional radiology to do extra procedures. So some of the radiologists do like surgical procedures. They instead of doing a surgery residency, they do radiology residency and then a fellowship. So she did a fellowship here at Sylvester Cancer Center, University of Miami, and then she stayed on in faculty. So she's going to talk a little bit about radiology and then a little bit about her procedures that she does. Just a warning, I did see the slide. She is showing some graphic pictures, so if you're the person that kind of closes your eyes during Game of Thrones, then maybe I have to hold my phone up while watching it. If you're one of those people, just kind of, but otherwise, you know, you can look wide open. Okay? Okay, thank you.
Morning.
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 Hi, how are you? So Dr. Benjamin gave a lot of the talk, so I'll just go fast and keep it light. When you ask if you've ever met a radiologist, most of no.
Can't hear you.
Okay. Maybe this is
lower. Better?
No.
No. Tend to get closer to it.
It's not that loud. I wonder if we could swap that one out. Yeah.
Better? Yeah.
No?
No? Now I'm gonna get a little shy about it.
Okay. I'm just gonna have to.
How's that? Yes, no?
No.
No.
Maybe just
Just hold it. Yeah, better?
You right up on.
It's so strange. So radiologists, we always laugh because we're the ones kind of in the dark. We love medicine, but are a little shy of patients. And then if you ask who the interventional radiologists are, we were the ones in that room making too much noise, so they had to find something to do with it. We like to do everything minimally invasive, small, and maximal impact sort of thing. So nothing to disclose. Radiologists and sarcoma, like I said, you don't often meet all of us, but you've had an imaging study. Like everyone's had some sort of imaging study. And we love to see. We're very greedy about pictures and different machines and modalities, and it's like everything is a different shaped donut that you go into and you get a different answer coming out. Diagnostic imaging side, what are we supposed to be doing? What we should be doing is identify there's something there. There's a lump, where is it? What does it look like? And then if we can, look for other friends in there and stage of disease. If you see one thing in the abdomen, like Dr. Benjamin showed, is there something in the chest as well? What we would like to do is make the imaging so great as if like you could just scan someone and know what is there, how much is there, and what it is. And if you meet some of my colleagues, like Dr. Tai Subbalong, he can tell you off the images, oh, that's going to be that. And he's right. You know, they just are a different breed. For us, on our side, the interventionalists, we do a lot of procedures, but we always do it with some imaging device in hand, and we're with you in the room. So it's a very intimate relationship when you do finally meet us. Most of the time, most people kind of meet us for a biopsy. It's very different. We're trying to get a lot of tissue through little things. And then we give a lot of access for treatment, so things like ports, PICC lines, pheresis catheters. That's when you kind of meet our group. And then if you really go kind of out there, is we do actually a lot of image-guided treatment. And I'm very lucky to be part of the sarcoma group where they think out of the box. I'm like, you should try this. I'm like, okay, I would never thought of that kind of thing. So one of the biggest principles in radiology is as low as reasonably achievable. So yes, we want to see as much as it's easy to get grady about radiation. I work in radiation all the time. So one of the things we try to do, and we all sign up for, is the Image Gently campaign that, you know, patients are young, we're all young, and we don't want to get older, so why should we do more radiation than we need. So one of the things we do a lot of is imaging with the two modalities that don't have any radiation. So one is ultrasound, and the other one is MRI. The problem is, especially if you get someone like me, I am super claustrophobic and I'm super noise claustrophobic. So anyone who's been in an MR scanner can tell you those things are loud and they're tight. So, just let someone know. We can always pre-medicate, but I hate those machines. What's much nicer is a quick x-ray. I mean, how fast is an x-ray? Everybody's had them. You can move around a little bit, they click a couple pictures, everything's done, you're out of there, good. CAT scan is equally fast. A lot of times you'll see us do it with contrast. So one CAT scan is actually 4 series. So as you get different contrasts, you see how it acts in the different phases of imaging. PET-CT is kind of fun, and it shows you a lot of good information, and it's got 2 studies at once. One is the PET part. What is a PET-CT? Is a positive imaging transmission tomography mixed with a CT scan. So it's asking the question, like, if I give you sugar that's radioactive, who's hungry, who's hot? So normal things are normal. If you look at your own PET-CT and your brain looks like it's on fire, that's great, it's working. So you have to get used to reading those. Angiography is what we do. So this is an X-ray taken in series to guide an imaging procedure, guide treatment, things like that. So anyone who's had a cardiac cath is really familiar with this. That little machine sitting over you, kind of taking the images in rapid sequence. So ultrasound imaging, it's real time. That's what's really great about it, but it's not always very easy to read. It's really, really, really dependent on how well the ultrasound waves penetrate in and then how good your machine is reading the changes back. So in our department, it's not these 2 guys, but these 2 guys. But that's what just a basic ultrasound machine is. So there's a small probe, and you have different probes you can pick depending on what you're imaging, and then the image will come up on that small screen, and then you see all those like knobs and dials. You can tinker with the images to make it visible. But as you can see, as opposed to the nice, crisp CT scans that Dr. Benjamin's taught, that's what you see in an ultrasound image. And for me, that's a great image. I'm very used to it. My patients, whenever I show them their own ultrasound, always look at me like I'm a little crazy. But I tell them, hey, it's a great image. They're like, okay, what did you see? So that's just a small difference there. MRI magnets. So everyone's here had an MRI. Anyone been through this process? We get all a little touchy because one of the most important things to remember is that your MRI magnet is always on. The magnet is always on. So you got to get the metal off. So it's almost like a fork trying to get in there. So you'll see the sign that says zone 2, don't cross here, check in with the technologist. Then you walk the next way, then they check everybody again, and then you make it into this tiny little cage of the giant machine. And then the technologist watching outside. This is an image actually of the inside of the scanner that you can actually see on the computer. So like while you're in there, your technologist is watching. And really, really, really nice centers, especially pediatric centers, will give you really good headphones, and you can actually watch a little movie and things like that. This is why we say the magnet's already always on. I don't know if you ever want to see silly pictures, just do like MRI magnet and metal things. So that's the floor waxer that's ended up hanging out with the magnet. So, in this setting, it's kind of funny. In reality, it like freaks all of us out. Something can fly. So that's one of the big precautions. And the reason it's so loud is the way you generate the signal is the magnet's on and it's looking at what your water molecules do as you give it a little electrical pulse. And it gets even more claustrophobic. To get the signal, you have to wear that the grid on top of you where the channel is coming in. So for me, like I said, super claustrophobic. But this is what you get, and it's so much nicer. So the last picture is a beautiful x-ray showing the hardware, everything's great, and that's like post-operative. But when you look at the actual bone, you can see what the soft tissue is doing on the edge. You can see how the bone is looking in there. You can see the edema. And really, really good sarcoma radiologists will tell you kind of preoperatively, like, hey, how much necrosis do you think that's in there? Does the thing actually get smaller? No, but it gets more dead. And I'll take more dead anytime. This is just to show you, we use MRI as well to look at muscles. So this is a patient that we had done infusion chemo into the bone tumor, but one of the side effects you can get is the muscle gets the chemo as well. The chemo is toxic, so this is myonecrosis. So this is kind of looking, you can see the nice smooth gray, and then the post, when you give enhancement, all that angry white stuff is telling you, hey, the pain is real because the chemo went after your muscle as opposed to just the bone. But MR gives you this gorgeous, gorgeous soft tissue detail, and the patient really has to work to get these images because these are long studies. For every one of these sequences, it's 15 to 20 minutes. So x-rays, like I said, super quick, but a lot of information. So the first picture you can see is a 24-year-old male with osteosarc, and he told the story that he was just kind of walking around and something snapped. Like, yes, something snapped. So that's just looking at the bone overlap. What you don't see here is you think, oh, maybe it's just a really bad fracture, car accident, something like that. And there's actually an underlying mass in there. And then this is looking at x-rays quickly. The orthopods love a quick x-ray to see where their pins are and where their fixation is. This is the same patient who had the post-operative image. Again, the x-ray really shows you a lot of information, a big part of the body, beautiful alignment. You can see little staples over it. So it's a lot of information very quick and no radiation. This is just to show a chest x-ray, and I think Venkat show it. So the first one is pre, there's nothing really there. And then with the chest x-ray, when you're looking for changes, you're looking for one of these things doesn't look like the other. So when you look at the image close to the knee, near the L, there's kind of a little vein that's developed. That turns out to be a mass. But we can do better these days. So you can get a CAT scan. And you can see a lot better. So I kind of gave the same kind of image. This is a different patient, but you can actually see what might feel like one blob on an x-ray. You can measure the size, you can measure the number. They can tell you treatment response as to, did it get smaller, are there more, and is it more dead inside? Some of the treatments, as you give them, and Dr. Trent probably went over this, that the treatment itself can cause it to swell, but the inside is not as alive. So these are the nuances you get with CT that you're not going to get with x-ray. But there is a cost for every time we do this. So there's more radiation with this. So you can kind of mix and match as you go through treatment. So let's make this work. This is that same patient, the x-ray on one side, and this is the CT. You can click on something.
Oops. Do you need the?
Yeah, I can get like the video. I should have put it to play automatically, but it makes me busy. Are you able to hit the picture on your screen? You just hit the one on that. So this is actually rolling through the CAT scan of the same patient, and you get a feel for that there's a soft tissue mass around it after they fix it. So again, just a lot more detail with the CAT scan than with just an X-rays. So PET CT, just to show you, outside will say PET CT radioactive material. Again, another donut that you go inside. What's different here is what they gave through the vein. It's not a iodinated contrast. This is a sugar that lights up. And so just to show you one of my patients, the top image there is a hypoattenuating. It's a sarcoma. And then underneath, you can actually see how that's acting. You see the bright color there? That's telling you it's active. The other thing behind that is completely normal. That's just a kidney pushing the sugar out. So that's how the nuances you see it. And you use this response. This is how a whole PET CT looks before you fuse it together. It's me, I'm not holding it close enough. And then that's the actual procedure where we put 2 probes in there. We actually put a total of 6 probes in there to treat. But what I like about the PET CT is this post-imaging response. So even even though they have a gray image there, you can see that this thing is dead because it's not taking up the sugar. So this is why we love PET CTs. My patients will ask, why is it a PET CT as opposed to CT this time? It's like, it's a different piece of information. Because in patients where the CT may told you something got bigger after treatment, it may be bigger but more dead. That makes sense. So with us, we have the funniest group of people you'll probably meet in the hospital. We're all a little nutty and we enjoy each other and we spend way too many hours together. So it's like a goofball family. My patients will tell me like they'll ask what soap operas going in the preoperative area sometimes. But you do get a preoperative workup, you meet someone at a time, you get consent, we talk about the different procedure times, infusion times, vancompression, different things. But we as imagers, because we're doing everything we can through smaller holes, we're a little finickier about labs. So things like blood thinners you really want to tell us about. I've had actually a lot of fun with vitamins too. I've started asking that question. So some patients take different vitamins that make you a little more propensity, more tendency to bleed, and you kind of don't want to find out afterwards. So I usually ask my patients, you know what, just whatever the vitamin is, just stop it for a couple weeks ahead of time and then come have your procedure with me. Some patients, because they're going to be lying down a long time, especially as women, you can't get up and pee, so you'll get a Foley catheter afterwards and we'll check pulses and different things. Our intra-procedure team is also ginormous. So this is Kevin, and he's wearing full lead. Like I said, we wear radiation, we're in radiation, so we'll wear the full coverage. This is one of our tables here. We like to keep everything clean. There's a lot of drapes and a lot of this and a lot of that. That Henry's sitting in the angiography suite. So that little arm is what takes the pictures, and we do different angles and different things. And with the newer generation, you can actually take intra-procedure CTs, and patients all have different choices. And so you tell me what you need. A lot of my patients, majority, do moderate sedation. So you're there with me, you're with the team, and you tell us, I need a little bit more, I need a little bit less. It helps me a ton because you hold your breath. Other patients tell me, no way. So it's gonna be general anesthesia, you're gonna be intubated, that's okay. A lot of the monitored anesthesia care, I don't know if you've had colonoscopies or endoscopies, they just give the white fluid going through the line. For me, that doesn't work a lot of the times, especially when you're doing liver-directed treatment, because the liver, every time you take a breath, goes up, goes down, you can't see what you're doing. So you need a breath hold. And like I said, we do everything together. So you'll end up with groups of random people like this. So I usually make everybody at least go and say hello and introduce their voice, because it's like, it's happened to me all the time when I make the mistake of not introducing myself. They're like, I met a doctor, and then there was this weird nurse who did the whole case. And I'm like, yeah, I was the weird nurse, sorry. Biopsies, just so you can see kind of this, everything to me is a cartoon. So this is the stages of what we're doing. So we try to get more through very little. So you'll put an outer needle like a straw. Through that, it has a little sharp stylet to get you there. Then in that, you put a biopsy gun. Anybody who's had a biopsy, that click, when you hear it, it's weird because it's like kind of right on top of you there. So hear the click ahead of time. I usually play it once for my patients so nobody jumps. And then you can even do FNA, which is tiny, tiny thin needles. So my gauges for these are 17, 18 gauge. So think of like the inner filament of a pen. The sarcoma guys, like if you need Thai, who are doing a lot of peripheral lesions, they'll go big. So they'll do 14 and 16 gauge, and anyone who's had a breast biopsy, they're a little nutty. Like they'll go 11 gauge, and it's like, hey, that's a full pen size. But we're minimalists. So just to show you, just to kind of go through it. So this is another ultrasound picture. So again, kind of blurry diagram, but great because I can see my needle real time. When you biopsy lesions, we get touchy about looking and seeing where we can go because you don't want that black center. You want the active live stuff. You want to see the change. So that's what we're looking for and targeting it. Sometimes you can see it with ultrasound, and sometimes you got to pull the CT and you really see. So you put the cannula in, you put the stylet out, and then through that, you bring this little biopsy gun, and the tissue falls into it, and then it shoots around and gives you a core. And this is what you're digging for. These are tiny, tiny, tiny little cores. And the kudos go to pathologists because we are mean and we tell them they get enough and they always want more, and it's always kind of a fun conversation with. But if you meet someone like Dr. Rosenberg, he does everything with tiny, tiny cells. You can send him a little FNA and he gives you a diagnosis. It's incredible. The man's a walking encyclopedia. So chemotherapy access, that's when you'll meet a lot of radiologists. So these are the catheters that hang outside. So people probably are familiar with it. We kind of look at the inside part. The PICC line, that funny little, this is a BARD, so we use BARD at home. But the little purple catheter, it's irritating because you got to work it into your shower routine and everything like that. And I can tell you in South Florida, I encourage everyone to shower. The phoresis are even weirder because it hangs underneath, but we try to tunnel it such that it's under your shirt or under your tank top so no one sees it. It bothered, like I met a gentleman who was so funny. I met him on Friday, and his biggest pet peeve about the catheter is that people stop him to ask. So I told him, come up with a better story. And he's like, yeah, I haven't had a great story yet. It's more intrusive. We try to make it hidden, but this is what we look for under the x-rays. The catheter coming in through the chest wall, into the vein in the neck, and the tip goes into the heart. So when you give this chemotherapy, it's not going around the skin and everything like that. It's getting there and getting done. Same thing with the PICC line. It's really an IV, peripherally inserted central line, but it ends in the heart. So when you give that medication, it's going where it needs to be, as opposed to those little IVs. Patients will tell you, and it's true, like the veins are scarred. And some of the chemos, they're toxic in the veins, so you want to go deeper, you want to go further. So this is actually what you see on the ultrasound, the little needle in the vein, that's what we look for. And that's the little probes as opposed to the different machines of like where we're going. It's right above the clavicle. This is the crazy drape. And again, your patient's with you, so the patient's head is turned like this while you're looking at the neck here. And then we start tiny, and then we work our way up. And that's the most blood we want to see. If we see more blood than that, we kind of get a little freaked out. So ports are great because once the port's in and it's healed up, it's yours. It's under your skin. It's that little button. And I encourage every single patient, feel your port, know your port, because I want them to tell me if something doesn't feel right. And patients will tell you, like when you flush it, you taste the saline. That's good. I like that. But if you don't and you think something's wrong, just stop and ask someone to check it. I'd rather check 18 ports and have nothing wrong than miss a chemo going the wrong way or something like that. So these are a couple of the ports that we use. There are so many different options, but it is under the skin. And I always like this drawing, where when they access the port, you're under the skin so that needle comes from outside. So remember the EMLA cream, your good oncologist will always give you a little tube. We try to remember to give it out as well. And it helps and numbs the skin, it's worth it. Just makes a huge mess. This is a crazy picture, but this is like the best picture I have of port infection. When they did nutty sutures. My sutures are all under the skin with tape on top. I don't like to see anything. But if your port looks like that, it's not right. So if it hurts, it's yellow, it's pink, it's red, just call. You just want to be on top of it. You can call us because we're the ones who are going to take it. And we're always around somewhere. But that's why I tell everybody, know your port. And then you can choose, when you come to my department, we show you all our different ports. And usually the oncologist will pick either dual lumen or single lumen. But patients are all different shapes and sizes. So how that would work for me may not be for some other patient. So we have everything pretty much available. And it's kind of funny, like, what do you mean choose? I'm like, it's okay, tell me what you think you want. And some patients have researched it, and they'll tell me, this is what I'm taking today. It's okay, that's easy for me. This is the standard port we use, that's the dual lumen there. If you see how it says the CT, that's actually really, really nice. It tells your technologist that they can access this port and they can power inject. So instead of starting an IV every time you do a CAT scan, they can access your port and put the contrast through there. Some of the older generations, it's really hard to find that little piece of information, so you've got to wander around with the card. Here, the newer generations are saying this. So if they have questions, sometimes they'll shoot an extra x-ray just to see, like, hey, is this a power injectable port? So moving to the weirdest world of the thing is ablation. So I do all the biopsies, same sort of thing. So patients tell me, well, while you're there, why can't you take it out? I'm like, well, we can, but we have to do it well. Anybody can do a procedure, but is it done well and do you feel well afterwards? So the way we do our ablations, and I think the most important thing when you go to a center is when you get it referred for these kind of goofball, off-the-wall procedures, it should be a multidisciplinary conversation. You should have an oncologist be on board. You should have seen a surgeon. You should see a radiation oncologist and then see us. And we all do everything together. Then come meet us in clinic. It's much nicer to meet the person who's going to do the procedure ahead of time than to suddenly meet them the day of. Some patients don't want to. They're like, you're just doing the procedure. And like, okay. But, you know. Meet the anesthesiologist. So we cause anesthesiologists a crazy amount of stress. Surgeon is different, right? So they have full control. They're holding the tumor in the hand, and Dr. Goel will show you gorgeous pictures of like what control they have. We're trying to do everything through tiny holes, so they're always wondering like, what in the world are we up to over there? So meet the anesthesiologist, and your anesthesiologist should know your procedure person because some of the different treatments require a different type of anesthesia. Most of the ablations we do are under general anesthesia. When I say most, is I have some patients where general anesthesia is more dangerous than my procedure, so then I'll pull the plug and we'll work together. But imagine biopsy, it's quick, right? I'm trying 15 minutes. So you hold your breath maybe 4 or 5 times. For the ablation, because I want to be precise through the treatment, it's the same position again and again and again. It's cruel to put someone through that. And then we usually keep most of our patients overnight. Many patients could go home, but it's not fair to your family. If you're going to do something funny, do it with me. It's okay. You know, and yes, you won't sleep because you're in a hospital and those beds are atrocious, but I'd rather you do something like nausea, pain, anything. Do it in-house and then, bother your family later. Be kind to and send them home to sleep because they have a really rough day. At least you got general anesthesia. They didn't. They're just sitting there waiting for me to finish. It's brutal. And then we follow up our procedures. So you will see us again because I want you to tell me, how did you do? Should I change anything different? Did this not work? Did the nurse not do this right? Let me know. But it's an extra visit. We try to do our visits in combination, so I'll shimmy up to Dr. D'Amato's clinic and just kind of appear. It's a lot of fun. So this is our clinic, and we have all these different people, and we have different days, but we do our clinic kind of silly, like we'll do our clinic together. You may see me, you may end up with somebody different on your procedure day, but we're getting there. Different types of ablation. The most tried and true is radiofrequency ablation, and microwave ablation. So it's putting a probe, and they're different shapes and sizes, and I've just done my renderings, so they're prettier than my CT pictures, where you're applying heat. So you're literally cranking up the heat, just like a microwave, giving them causing the protein to denature, and tumor is dead. And there's all sorts of nuances to that. Simple. Cryo is one of my favorite ablation techniques, but it's super long and kind of takes time. But it also gives some pain relief, and it's fun to kind of see the ice ball, but longer procedure. Irreversible electroporation, whenever we have some discussion in Miami, I always talk about it because they always know. Also known as the nano knife, which I have patients come to me for gamma knife, but that's the next guy. It's a different thing. And then chemical ablation is old treatment, but it works. It's literally taking something toxic, and we usually use alcohol, putting it through a tiny needle and just kind of burning what's there. But for some tumors, it does work. I'm just going to show you the IRE device because that's what everyone always asks about. Just a little machine with a generator, and then that's the probe. It's a 19 gauge probe, so on the order of your biopsy probe. The problem with this probe is it covers 1 centimeter distance around, so you got to put multiple to actually build a treatment zone, so anywhere from 4 to 6 to get a good ablation. And then that's the AccuSync device. So IRE is irreversible electroporation. So you're giving electricity to cause pores in the tumor cells, and then who knows why they really die, but we like to believe that the body decides this is a useless cell and gets rid of it. There's some theories on that, but it's not worth it. But that machine actually gates with your heartbeat and gives this at the non-refractory time. So instead of like jolting you, it's kind of on a dead time that kind of gives it. So that's how we place the needles in our crazy little CT scanner. I don't think that's me. This is what we talk about. You're building an ablation zone, so this is the house shape. But we want everything to be no closer than 1 centimeter and no further than 2.2 centimeters apart. And let's see, can you hit the screen again? So this is a little dramatic, but just, this is the noise it makes. And those are all the different probes and shape. This is actually Dr. Raj's picture. It always stresses me out when it does this stupid thing. So I think it's my voice complaining. Can you do it again? Because those are good circles. But just so you see, like, it's just a weird thing. I can't ever describe it, so I try to show everyone a picture in clinic, like, this is what we do. And the poor anesthesiologist hates our room because the donut is on my side, and they're in the corner behind. You see that little screen? So they're all the way over there. So they're literally like just stuck in that corner. It's terrible. The other way we come at tumors is through the arteries, and this is great. So tumors like blood. So can we cut off the blood supply to tumors? That was the initial thought, and then it's like, can I do one better? Like, while I'm hanging out there and cutting off the blood, can I deliver some chemotherapy or radiation therapy? So there are so many different options out there, so I won't go through all of it, but just to show like the different beads and the different products, and this is kind of a hot new field in medicine. These are the radioembolic beads. These are tiny beads. So that's showing the glass ones are 20 to 40 micron, so super teeny tiny. And then the big ones, the resin ones, are 40 to 60 micron. And then it has a different delivery device. So this is the little box that we kind of deliver, and you have to protect yourself because you want the radiation to go in, nothing to go out, and a closed system, and it's a whole dance. But what are we doing? It's really just to get a catheter either through the groin, and now we're doing a lot of work through the wrist because patients are young and that artery is wide open, and it's a good choice. It comes from the cardiologist literature because they run into the heart all the time. It's on their way if they pop through the right wrist. For us, we've got a little longer to go. And then we get through to, and we have all these different shapes and sizes of catheters and things to get there. This is, and I apologize if the other one, so it's the same patient who had the sarcoma, then you click the other one. It runs too fast, I don't know how to slow it down. But that's actually just showing, there's a catheter in the artery showing the vascular blood supply. You can kind of see that blush on the side that comes. And this is, again, to give higher doses of doxorubicin in different patients. You can actually get right into that vessel and infuse it over a short amount of time. So it's one of the things we do. So really brief, but meet us. You can actually call and see us in clinic. I have a couple patients who just come and make me read their scans for some reason. But you know, it's a fun group. We have a lot of fun, and we enjoy what we do. If
you have time for maybe 1 or 2 questions.
Does anyone have a question or two? You can wait for the panel. Okay.
Yes.
So I have just a comment. I had ablation done this summer, 2 microwave and 1 cryo ablation, and it turned out wonderfully. clinicians and everybody who's in the cabinet to have your doctor double check on the medicines you're on. Because I was not told to go off the Votrient that I was already on, and they did tell me they would want me to continue on Votrient anyway. Votrient has, and all of us overlooked this, one of the side effects is it keeps you from healing during surgery. So I had side effects of like coughing or blood for 6 weeks after, and nobody could figure out why, because it's not normal. And it was just simply that I was still on Votrient.
So you had lung ablation?
Yeah.
No, we usually, depending on what kind of part you're doing, we'll kind of stop it 2 days before, and then we talk before we restart. Like, I want you to heal before I give you something that's gonna give you symptoms back, but no, that's very important.
Yeah, I was told to stop my medicines, like 2 days before.
Mhm.
But the oncologist said, "Oh, we're gonna want you to continue on Votrient.
Right.
You're going to start back up." There's no clear when to start back up, so I literally got out of the hospital 2 days later, which went well.
Mhm.
And started taking Votrient again. So I think some of the newer, or, you know, the ablation is kind of a newer thing, so maybe with some of the newer drugs that people are on too, it may have gotten overlooked.
And it's totally true, and I usually will ask the oncologist before I restart, and then we're different, like, we trust our therapy, so we'll sometimes ask 4 weeks, like, hey, just let it heal before we restart. But I will say with a lot of the monoclonals, we start them pretty fast. I'll usually wait like 2-4 days, just call and say, hey, are you feeling good? All right, just start back up, because I don't want to miss something, because I'm cheating, right? So I'm ablating like 2 spots here, but I didn't cover you head to toe. So you feel nervous, like not giving the full systemic coverage as long. And we are better.
Successful. I mean, it was successful. Really good option. A lot of people don't know about it.
It's some people like it, some people don't, and the problem is our studies. So you saw the pictures that Dr. Benjamin put up there. You have patients taking one therapy versus the other. You can't placebo a treatment, like you're not. So we have these collections of data, and we are bad. We're fun clinicians, but sometimes I think we're terrible researchers. Like we don't keep it clean. So we'll show you these patients and we'll say it improved overall survival, and then it's like, come on, guys, you give this therapy afterwards and this treatment afterwards, and then you switch from microwave to RFA, and then you use this machine and that machine. It's like none of this is clean. So you can't ask the question, if I'm so-and-so with this tumor at this time, will this treatment give me how many months? We kind of say like, yeah, it should work. You should do better.
How do you decide which treatment to use?
Oh, some of it's my comfort, some of the patient's choice, some of it's really the tumor board. We talk about it and say, so with this treatment, like the nanoknife I showed you, saw, it's 6 probes to get a small ablation. If something's 12 centimeters, I'm going to be doing that for like 10 to 12 hours. It's a terrible choice. So then I'll go to something like a cryoablation where you can put 4 probes and get a 10 to 8 centimeter ablation, so a good one with treatment, and it's okay, but is it going to be safe to make that kind of, ice ball in that location? You have to choose. A lot of the heat-based therapies, you have to pick what you're next to, so it's all about real estate. If you're right up against a major vein or a major blood vessel or a major bile duct, you don't want to be burning there. So you have to go a different route. We cheat because we have like literally every ablation material available in University of Miami, so I pick and choose. There are other tricks you can do. So say you have to do a heat-based therapy and you're right up against a vein. You can actually do 2 things at once. You can come in through the vein in the neck, sneak down into the hepatic vein, put up a balloon, and just shut down that vein for a little bit, treat gently, and then open it back up. And there's all sorts of different things people are doing. And then sometimes you just ask the surgeon to help you out. Look, I can't get there. Can you get there? So they'll go in the OR and it's beautiful. They'll hold it in their hand with the ultrasound machine and put the probe that way. The only thing is I don't give them what I get in the CT scanner. So when you come to ablation with me, I do a half CT scan ahead of time with contrast to see where is this thing. Even though I know we've done pre-imaging, but I want to know right then with all my stuff still there and the anesthesiologist still waiting, I'll do a post scan. And if I like it, we're good, we're done, which most of the time is true. But if there's something I don't like or the treatment wasn't enough, I'll go right back in. We're there, we're going to do it together. So that's the kind of precision that I want.
Great, thank you. That's all we have time for questions right now.
Dr. Venkat, thank you so much, and she will be available, I guess I just have a loud voice. She will be available for questions after. Okay, so the next esteemed speaker I would like to introduce is Dr. Neha Goel, who she went to University of Illinois for medical school and then did residency in surgery. So she's a surgical oncologist at Columbia University. And then she did 2 fellowships, one at Fox Chase one at Brigham Women's, which is affiliated with Harvard, and then a second one at Fox Chase Cancer Center, which has both centers have large sarcoma programs. So we recruited her here to University of Miami to help us with treating our sarcoma patients. So she has a lot of experience, and she's going to talk to us about different surgical techniques that she does. And she's also very good at karaoke. She was upset that she has the karaoke.
So I also have a very loud voice.
So you want maybe you want
Maybe I want the other one. Can everyone hear me okay? Okay. Great. Okay, so I'm going to talk to you about the surgical management of sarcomas. So in general, as a surgeon, our mantra is a chance to cut is a chance to cure. And so I'm sure you guys have learned about all of this in the past 2 days, but soft tissue sarcomas are tumors of connective tissue origin. So when I see a patient, what does connective tissue mean? I describe it as kind of the glue that holds everything together in our body. It's tendons that are holding bones together. It's fat that's holding our abdominal organs in place. It's linings of muscles. It's linings of blood vessels. These are rare tumors, as we know, that represent less than 1% of all solid tumors. 40% of the time they're found in the lower extremity or the lower legs. 20% of the time in the upper extremities or upper arms. 16% in the retroperitoneum, which is a part of the body, which I will describe to you in greater detail, that lives, basically anything that lives in the back of your body. So your kidneys, the major blood vessels like your aorta and the vena cava live there. And then head and neck about 10% of the time, and the trunk 10% of the time. There are more than 50 different subtypes, but the most common, the ones that I'm going to focus on today, are liposarcoma, which comes from a fat origin, and leiomyosarcoma, which is more of a smooth muscle cell origin. So when I first see a patient in clinic, the key thing that I do, like all the other clinicians here, is a history and physical exam. History, I want to know when you first saw it, if you felt it, if it's getting larger, and then I perform a physical exam, which is crucial for surgeons because I need to know how large this is. I feel it to see if it's movable, is it stuck to the muscle underneath, and then I examine lymph nodes because in certain types of sarcoma, it's very rare, less than 5%, like angiosarcoma or epithelioid, they can travel to the lymph nodes as well. Then I do a biopsy, and that's where I refer to my interventional radiation colleagues, interventional radiology colleagues, like Dr. Venkat, who will perform the biopsies for us. Then we send the biopsy to pathology. They tell us exactly what type of tumor it is, and that's crucial because, as you know, sarcoma treatment is very dependent on the type of sarcoma. And then imaging. And so this is key for surgeons because we want to know, based on the CT scan, which is what we use for abdominal or retroperitoneal sarcomas, exactly where the tumor is with respect to blood vessels, major blood vessels, that if I take those blood vessels, there's no way to survive. So I need to make sure that it's not near one of the major blood vessels in the body, as well as looking at an MRI, because the MRI for a lot of the extremity sarcomas help us look at muscles and nerves. So we can't look at nerves on the CT scan, so I rely on MRIs for that. And then we make sure that the disease hasn't spread, so we get staging imaging as well. So imaging. So the key concept is assessing for resectability. Can the sarcoma be removed completely, and can it be removed safely? So I'm evaluating, like we discussed, and I'll show you images in a little bit, the relationship of the sarcoma to surrounding structures. Is it near vital structures that can't be taken? Or if that structure can be taken, can I remove a small part of that blood vessel and reconstruct it, which is basically taking a tube graft or kind of like a straw that's sterile and sewing it together to recreate the plumbing of the body. And so what can't be put back together? So obviously if the tumor is involving both kidneys, that's a contraindication because we don't want to necessarily put a patient on dialysis from surgery. If it's involving the portal vein is a main vessel that feeds, basically takes blood flow from the gut and basically supplies it to the liver. And that nowadays we are able to do small, if it's involving a small area in the portal vein, we can resect that area and fix the top, like the plumbing of that area. Or if it's involving the superior mesenteric artery, which is the main blood vessel that feeds the gut, if it's involving that, we unfortunately can't do any surgery to remove that part of the vessel, because if that's gone, then there's no blood supply to the gut, and that's unfortunately not a viable solution. The next step after I've reviewed the imaging is I take the patient and I discuss them at multidisciplinary tumor board. And the main surgical question, and you'll hear this over and over again, is what is the best way to remove the sarcoma with an R0 resection and with the least amount of side effects for the patient. So R0 basically means that there's no tumor that is seen on the cut edge of the specimen to the naked eye or under the microscope. So basically this is a right chest wall sarcoma that I removed recently. And what the pathologist does is they cut this specimen into thin slices, as you can see, and they check each of the margins. They visualize it under the microscope to make sure that there's no disease that's seen. And that's what indicates an R0 resection. And that's our goal, because that gives us the best option for cures, to make sure we can surgically remove it without any disease left behind. And once again, it's a team effort. If I think that this tumor is too close to a major vessel, I discuss with my medical oncologist and radiation oncologist if we think giving treatment ahead of surgery, like chemotherapy or radiation, will shrink this a little bit to remove it off a major vessel, if that can be helpful to allow us to do surgery more safely. So the next step, surgeons love anatomy. That's one of the major reasons why we went into surgery. But we have this guide called Netter, and that basically has every possible surgical image that we've studied many years in residency and medical school. But this is, for example, an image of the right lower extremity. And so you can see here, these are the muscles of the thigh. This is the femoral nerve, this is the femoral artery, and this is the femoral vein. So these are the key structures that I'm looking at when I see a patient with a tumor of the thigh. And then we go on to look at the abdomen. So the abdomen is very complex, and it's divided into two compartments. This is called the intra-abdominal portion, and this is basically a cross-sectional image similar to what you see when you have a CT scan. It slices the body up and down while you're laying down. And you can see here's the liver, this is the stomach, the inside of the stomach, this is the spleen. These are some of the organs that lie inside the abdomen. And then you have this thin layer called the peritoneum that surrounds all of the abdominal organs. And behind this layer is the retroperitoneum. And in the retroperitoneum, you have your kidneys, you have the inferior vena cava, which supplies blood back to the heart from the legs. And then you have the aorta, and you have fat in that area called retroperitoneal fat, which surrounds the kidneys. And this is where the majority of the retroperitoneal liposarcomas come from. So the next step is operate. So I have a lot of pictures here. I apologize if any of them are disturbing. But so the key here is there's two options. So we have open surgery as well as minimally invasive surgery. And so what open surgery means is, and this is kind of what we do a lot of nowadays for sarcomas, because sarcomas are larger tumors. The goal is you want to remove the tumor safely, you want to get negative margins, and you do not want to break the tumor. So that's the key for any sarcoma, is you want to make sure the tumor comes out intact. And so we make the incision to accomplish that safely. So this is an example of a thigh sarcoma, and I'll go into greater detail about this tumor in the next slide. The next option is minimally invasive surgery. And so I'm sure you've heard about it for gallbladders, for appendixes. You go in, you go through a small 5mm incisions, and you basically take a camera that goes in as well. And you use long instruments to do your surgery. I don't know if you can see, but this is the camera. We're looking at a screen here, and it's all done through basically these long instruments that serve as extensions of our arms. And the robot is actually done similarly. It's basically, we're sitting at a console, and there's arms of the robot that have instruments that are moving, that we are moving from the robot, but the robot is helping with the surgery as well. But in sarcoma, this is not as common. I will offer minimally invasive surgery for a lot of gastric tumors that are small. I can mobilize the tumor, and then I remove it. Once again, you have to make that incision to remove the tumor to make sure that you don't rupture the tumor. That's key. So if it's an 8 centimeter tumor on the stomach, I can mobilize it using these small instruments, but I still have to make that incision to remove it. So you can save a few inches through minimally invasive doing a combined effort. So the surgical principles. So in extremity sarcoma, if you want to, ideally, if you can spare the limb and function while obtaining an R0 resection. If not, then amputation is the next step. But there are some newer techniques that we're using in between, and I will discuss that. You want to make sure the incision is along the length of the extremity. You want to include the biopsy site in your resection, and you ideally want to resect about 2 centimeters to make sure you can obtain that R0 resection. You do not want to rupture or break the sarcoma, because that can seed the area of the surgical bed. And you want to document the margins and orient it so the pathologist can understand exactly where you removed the sarcoma from. So for example, this is the upper right thigh sarcoma. This is basically the anatomy. So if you take this is living right here. Deep to this are the femoral nerve, vein, and artery. And when I remove this, I make sure that my pathologist knows that this is, it's called, this is superior, it's up towards the head. This is inferior, this is lateral, this is medial. And that deep to this, I mark where the nerve would be, where the artery is, and where the vein is. So they can actually look at each of those margins to confirm that I truly have removed the entire tumor with a negative margin. This is another example of a thigh sarcoma. And this is the surgery, and this is the mass. So once again, we're making sure that we remove everything in its entirety. So isolated limb infusion is a technique that we're doing more often nowadays, and it's for patients who have locally advanced disease that is nowhere else, but basically has found multiple areas, basically in the legs, where it has developed. And this patient has had radiation before, as you can see, but there's still pockets of disease here as well as here. So the main goal of this procedure is you put a tourniquet on the leg, and you have catheters that are placed by our interventional radiologist before the surgery to feed high doses of chemotherapy to that leg. These are doses of chemotherapy that could otherwise not be tolerated. So it's doses that we hope will help destroy the tumor just by infusing the chemotherapy in that area. So now I'm going to jump to retroperitoneal sarcomas. These account for about 16% of all soft tissue sarcomas. The most common histologic subtypes are liposarcomas, leiomyosarcomas, and patients often present with vague symptoms when they see sarcomas, when we see retroperitoneal sarcomas or abdominal sarcomas. The main symptoms are abdominal pain. They can have early satiety, which means they get full easily, and this is because the tumor can be in the stomach and just causing compression of the stomach so they get full, and it can cause abdominal discomfort. So once again, as a reminder of our anatomy, the most common type that we see, or that I've seen, are leiomyosarcomas arising from the inferior vena cava, the main blood vessel right here in blue, and fat in the retroperitoneum, such as this fat that's located around the kidney, and that can lead to the liposarcomas. And so the surgical principles of retroperitoneal sarcomas, once again, is you want to resect all involved organs and structures to try to obtain that R0 resection. It's much more difficult in retroperitoneal sarcomas to obtain an R0 resection. And as you can see here, this is a sarcoma rising from the fat behind the kidney. This is the kidney, and this sarcoma has pushed everything over in the abdomen. So otherwise, you would see the kidney would be located right here, but this tumor has moved everything around. And so as you can imagine, it's very difficult to obtain a negative margin along this entire part of the sarcoma, but that's still our goal. And sometimes if we think chemotherapy will help ahead of time, or if radiation can help to kill some of the microscopic disease that might be left behind, we do offer it in certain types of more aggressive sarcomas. And then this is an example of, this is the liver, this is the kidney, this is another kidney, this is the stomach here, and this is basically the inferior vena cava. And this is a leiomyosarcoma that's coming off the vena cava, and actually right at the junction where the renal vein is. And so the surgical perspective for this is, in addition to, once again, this is the vena cava, you have your liver here, this is the leiomyosarcoma, and you reconstruct here the renal vein and part of the vena cava. As you can see, this is like a big straw that's it's almost like plumbing. It's basically retaking the area that I removed to remove the tumor intact and replacing it with this so we can keep the blood supply. And now we'll go briefly move from the retroperitoneum, which is once again the disease that occurs in the back, to the intra-abdominal structures, the main ones being the stomach, the liver, the spleen. And this is a large, as you can see here, stomach tumor. It's actually just a gastrointestinal stromal tumor, a type of sarcoma. And you can see this is the kidney here, and it compresses the kidney, and it's basically coming off the stomach. And this is the tumor once it's removed, coming off the edge of the stomach here. And this is another example of a tumor also arising from actually the fat in the blood vessels around the colon. This is the colon right here. And one more type of surgery that we do is called metastasectomies. And this is when disease has spread outside of just that primary tumor. And for example, here, this was a uterine leiomyosarcoma initially that was resected out of an outside hospital. And the patient came back with a recurrence in the small intestines and near the colon. So this is the colon and the small intestine here. And this is the mass. And I'm done with all the pictures. I apologize for the pictures. And then this is some of the newer techniques that we use. It's called intraoperative brachytherapy. And this is when we work in conjunction with our radiation oncologist. When we think that we're near a vital structure that we can't take, this is basically beads that are on this plastic sheet that emit radiation only in one direction. So we work with the radiation oncologist to contour and exactly know where these beads will be placed. They come into the operating room, tell us how to place these, and we place them in areas where we think disease could recur because there is a close margin. And we sew these in, and this is deep in the pelvis here near the sacral bone. And once again, we confirm afterwards that after they get an x-ray the day after, just to make sure that the beads are all in the location where they should be. And that's it. Thank you so much for your attention.
Does anyone have any questions? Or we're hoping on, sorry.
I'll answer any questions.
Yeah, so we're running a little bit behind, and it is
noon, and I did hear my stomach growling. The next speaker, and maybe everyone will stop talking once I introduce the next speaker. Okay. And I'm using the yellow microphone. So the next speaker, I'm really thrilled to introduce Dr. Yechieli. He's the radiation oncologist. So everyone always gets confused between the radiologist and the radiation oncologist. So that's why we had both radiologists and radiation oncologists. So you see Dr. Venkat's a radiologist, and she looks at images, and then she's interventional, she does procedures. Radiation oncologist is a separate residency, and they use special radiation machines to kill a cancer. Now, so part of the training is Dr. Yechieli went to University of Maryland for medical school, and then he did his residency program at Henry Ford, which is in Michigan, and which is also where Dr. Venkat's from. And then he went to UM. So he went to UM, then UM, and then UM. Anyways, and he works very closely with us in the sarcoma program, and he's going to talk to you. He was the only one that actually kept on task, and he doesn't have a lot of slides, so hopefully we'll make up some time. And he's not going to be available for the panel because he's coming here, it's a special Jewish holiday, and hopefully he will not be in trouble with God for coming to here today. So anyways, really appreciate it. His family's probably mad at him, but hopefully, anyways, so really thank him a lot for coming, because this is extra special that he's here today.
Thank you, Dr. Donata. This is really an honor for me to be here and be able to speak with you. Tonight is Rosh Hashanah, the Jewish New Year, so it is pretty hectic at home, and thank you, my wife, for letting me be here. And she very much supports me being here. So thank you for giving me ample advance notice of this meeting and allowing me the opportunity to speak to all of you. Pardon? Shana Tova. It's going to be an amazing year coming up. My name is Raphael. No one can say my last name, so I just go by Raphael. And I'm a radiation oncologist, and that means I use radiation to treat cancer. And I'm going to try to give you a brief overview of what we do. Look, I'm on Twitter. You see the little birdie? So anyone who wants to follow, I tweet once in a while. Okay, I have no financial conflicts of interests. I have a lot of other conflicts, and I have a lot of interest in destroying sarcoma, but no financial conflicts of interest with this talk. Okay, so we're going to try to hit 3 points. We're going to talk about what radiation is, and brief overview of that. We'll discuss the role of me in treating sarcomas, and hopefully we'll have a bit of time for question and discussion. Let's go. So an overview of oncology, I'm sure you've seen this already, and you've met a lot of us. But I wanted to give a bit of an overview here. Where the medical oncologist, Dr. Tomato, Dr. Trent, they use chemotherapy or immunotherapy, either injected into the vein or taken by a pill into the mouth, and then it goes into the bloodstream and it goes everywhere. So that's really good, and it works really, really well. Surgeons and radiation oncologists, on the other hand, we treat locally. That means the surgeons cut out what they cut out, and radiation, we aim our beam at a specific area. So we're, at the same time, we all work together, and sarcoma is definitely one of those tumors where we, working together becomes a synergy. What is radiation? So I want to point you to C1. This thing has a pointer, right? Which one? The red one. First of all, one of the cool things about radiation oncology is just how smart we make ourselves look. See that? Look at that. It's like high school physics. Anyway, so the combined process of emission, transmission, absorption, radiation energy. That's what radiation is. Radiation, actually, what we're doing is we're taking the photons. I'm going to show you the next picture. I'm going to jump straight into this. Look at that. This is a radiation machine. We're going to go back into the history in a minute. But actually, look at this. We'll give a quick tour of a radiation oncology machine or a linear accelerator. Over here, see this thing? That's an electron gun. And that's in the back of the machine. And it spits out electrons through this thing, which is called a waveguide. And it's about 3 feet long. And there's something called a klystron behind it. I'm pretty sure the person who named this stuff was a Star Wars fan. And the klystron helps the electrons accelerate within 3 feet to about the speed of light. And then there's a really big magnet right over there. And it spins around the electrons, hits a target, and that creates photons which can be shaped. That's what we use. It's pretty cool. So let's go back in time now. In 1895 was when they first recognized that there was something called photons. They called it X-rays because they didn't know what it was. It was a ray, it was X-ray. And in 1896, 1 year later, they already started using it to treat cancer. That just goes to show you that cancer is a pretty old illness, and one that we, while making good headway in, we're still struggling with, and it's been a long struggle. In 1901, actually, they were showing an X-ray machine at the State Fair, and President Yechieli was assassinated. Not sure what that has to do with anything. Then a bunch of people won Nobel Prizes, and then using this technology. And then really where things took off is 1968 radiosurgery. That's when, that's what's known as gamma knife. It's actually a pretty old technology. It's very, very, it's incredibly precise and works really well. Goes to show you something that's created in 68 still goes. 68 is not old at all. In 1970, CT scanners were invented. We heard a lot about them, but that actually helped us in our design, in our radiation design, to allow us to treat three-dimensionally. PET-CT, we spoke about a bit, that was in 75. 1980 was a big year. Number one, I was born that year. Number two, that's when we came up with multiple collimators, the idea that we could shape the beams as the machines are going through. And also proton therapy was first invented in 1980 and first developed in 1980. In 88, we came out with something called IMRT, or intensity modulated radiation therapy, IGRT, using CTs, and then nowadays MRIs, image guided radiation therapy, to help us treat even more precisely, is in the 2000s. And where are we going now? Well, it's another talk for another day, but we are moving forward. Okay, so now when you talk about radiation, it's important to understand that the machine that we use, and there are different machines, is just a bunch of brand names, all right? So we have Hondas, we have Acuras, we have Mercedes, whatever car you really like, that's the machine you have. Similarly, when it comes to radiation, there's many machines and they advertise. So I'm going to run through them quickly just so that we understand what we're talking about. This is called the TrueBeam. This is what the TrueBeam looks like without its clothes on. That's what it looks like with its clothes on. And this is actually the machine that we use mostly in Sylvester. It's a very robust machine. It works really, really well. And when we upgraded our machine at Jackson, which is our county hospital, it completely changed our experience for our patients. That's been incredible. CyberKnife, this is what the machine looks like. The person who invented this actually was probably a Henry Ford fan. And because this does look exactly like the robots they use to develop cars. And that's the same idea. The entire linear accelerator is actually housed just in this little area. And it can be shaped and it can go in any angle around the patient. So a very, very flexible machine, works well. Tomotherapy is basically like a CT scanner, or it's a CT on rails, and there's a linear accelerator housed there. So there's actually a CT scanner here and a linear accelerator here. Again, it gives us very conformal treatments. Gamma knife. This is not the 1968 version. This is the 2019 version, but the same idea. 208 cobalt sources, which are radioactive sources in here, and we can precisely treat brain tumors. That's mostly what it's used for. But again, I just wanted to show you these pictures just to understand that these are the tools we use. These are the brand names you might hear or hear advertised. But what's really important is that you have the confidence in your doctor that they know how to use your tool. All right? Really important. MR guided, this is kind of next gen stuff, but we are now able to use, this is called V-Ray, our new machine, and where we can, the image guided aspect of our radiation treatment, we can actually use MR. And we just showed a bunch of pictures showing how much better the resolution is, especially in muscle and bone, using MR. So we're very hopeful that with this technology, which we have and we're upgrading at Sylvester, it's also going to be just very helpful for our patients and allow us to treat even more precisely and more effectively. Protons, that's the next big thing. We'll touch on this briefly. These machines are huge, huge. And the reason is, because I told you, to create radiation, you got to accelerate that electron. Now, a proton is about 1,800 times heavier than an electron. So to accelerate a proton, you got to have a machine that's 1,800 times bigger. Well, not exactly, but at the same time, you get it. And that's really the idea of why protons are, and proton centers are so large in themselves. The advantage, the theoretical and practical advantage of protons is because it's a charged particle. I'm not going to go into much, we can talk about it later if you want. There's something called a Bragg's peak, which is here. And the idea is the beam stops. As the beam slows down, as the proton slows down in the tissue, it gets to the point and stops. Now, there's uncertainty exactly where it stops, so you have to be careful about that. But the idea is that, especially in children, when we're treating brain tumors, it's the classic best example, if we're treating a brain tumor in a child in the back of their head, the only way to avoid radiation in the front of their head is with protons. Because any other form of radiation, it's going to have radiation dose that goes through. And the only guaranteed way to avoid a radiation side effect is how? Proton. No radiation. Okay? But then again, we do it well. Now, so how does radiation work? I do want to touch about this. So radiation works by damaging DNA. And the way radiation works by damaging DNA, I don't know if you noticed, but I like cars. So I'm going to talk about cars for a second. When I was 16 and I was getting my license in Montreal, apparently, by the way, I have a 12-year-old daughter. And here in Miami, you can get your permit at 50. Anyways, so in Montreal, I was at 16. So one of the things they tell you is that you want to walk around the car when you get it, before you get in, and make sure there's no cats behind it. Because they didn't have those things called backup cameras. Anyways, so what you can imagine what radiation does is it damages the DNA in the cells. Now, cells just want to divide. So imagine someone came in the middle of the night and took off all the nuts holding the wheel and the engine and everything like that together, okay? And they're just spread around the car. So everything's kind of still standing there, just, yeah. So you're walking around the car and you notice, you're feeling like, ow, what's that, what's that? And then you look down and you see, like for every single wheel, there are 5 bolts, they're all on the floor. What is this? So you go and you start putting them back together. Repair mechanism number 1. When you realize you just don't want to do this, you call AAA. And if AAA can't fix it, you call Geico. And you have good insurance, like normal tissue cells and tumor cells, normal cells have. You have good insurance, they just give you a new car. So that's what happens. That's how normal cells deal with DNA damage. Tumor cells, on the other hand, are teenagers. They don't care. They just get right in the car, start the car, and start driving. They just want to buy. And what happens if you have all the nuts holding the car together and not want? Yeah, the car just falls apart. And then you call AAA and they say, I'm sorry. And you call Geico and they say, I'm not fixing this for you. And so that's how radiation works. Not exactly, but yeah. So let's talk about sarcoma briefly. We went through this a lot. It's a rare tumor. It most commonly presents in the extremity, but at the same time, to each and every one of us who are either affected personally by it or treated, it's not a rare tumor at all. And I think that's important to understand and point out. We know that it grows along the muscle tracts most commonly. And practically speaking, when we talk about radiation, this is what it looks like. We do a CT scan or an MR scan or a PET scan, and we normally use all three of the images together, and we get an image of exactly where we see the tumor is. And we create we can see the tumor in this person over here in the leg, and we create something called a GTV, or a gross tumor volume, where we can target the tumor itself. And then we create around it the area, what we call CTV, or a clinical target volume. And we use that to say that we probably have microscopic tumor cells in the area. And then around that, we add a different margin called a PTV, or a planning target volume, because there's always uncertainty and they set up. And this is where something called IGRT, or image-guided radiation, and especially once we move on to MR, will be able to help us decrease that uncertainty. And then we create a plan. And in this case, this is a plan, a 3D plan. Pretty simple. One beam coming this way, one beam coming this way, one beam coming in this way, and you see all that exit dose. Now you see what I'm talking about? So for example, with protons, we'd have, this wouldn't be blue. But even this blue, just to think about it, it's only 10% of the dose. So it is low dose, no side effects for this person, they did really well. This is another case where we can be much more complex. Someone had a very large unresectable sarcoma in the pelvis, and this was difficult. And we were able to treat the entire tumor and the area around it with one dose, and the tumor inside of it with another dose, and made this resectable. So it worked really well. And again, the most important thing I want to show and share with you about this is that multidisciplinary management matters. And by sitting here and listening, Dr. Romano, Dr. Trent, myself, the surgeons, our interventional radiologists, really the key here is it's not any one of us alone. We're a team. And we're a team that's surrounding you. Because really the only person that really matters here is the patient that we're taking care of. Thank you.
If anyone has any questions for Dr. Yechieli, hopefully I've been pronouncing his name right. I have been, right? Okay. Does anyone have any burning questions?
Doctor, can you differentiate a little bit clearer the difference between the CAT scan and the PET scan?
Absolutely.
Why you pick one over the other?
So generally, classically, we'll use most centers don't have a PET scan in the actual radiation department. So PET scans are excellent because, like as described before by Dr. Venkat, what they do is they give functional imaging. They show us if the areas where the tumor are actually active. I can go into a whole another caller based algorithm to explain why that works, but I'm not going to do that right now, okay? But at the same time, that's where the PET does. But even a PET scan nowadays is always called a PET CT scan because they're always fused together. The PET, which is the functional imaging aspect of it, is done with a CT, and they're actually done about an hour apart, as many of you might know, and then those scans are fused together. So classically what we do is in our departments, every radiation oncology department will have a CT scan in the department, and it's matched up perfectly to the actual treatment machine. And the reason is because on the first day, we're doing that radiation planning to get those pretty drawings. Excuse me. What we need to do is position the person in exactly the position they're going to be able to be on for all the treatments they're going to get. So that's done with the CT scan in general. And what we'll do is we'll take that diagnostic MRI, we'll take that diagnostic PET-CT, and we'll use all that information using pretty powerful software to help us design exactly what that GTV is, or the gross tumor volume is, what the CTV is, the clinical target volume is, and plus using some anatomy and a lot of conversation with my amazing colleagues. Yes.
Why haven't upwards remedy been so far with sarcoma? And I know here in the doctor usually say that scan, other than the MRI. Is there a reason why PET scan is not?
Why don't we have the radiologist, why don't we have everybody on the panel, we can just have some, we'll have a medical oncologist, we'll have Dr. Venkat, Dr. Goel, I think that may be a better question.
It's a great question, and you're going to get a great answer.
Anybody have any specific radiation questions?
Okay, well, maybe Dr. Benjamin will ask that.
You can actually answer the question.
Okay.
He can.
I'll answer the question. I got asked the question. I can't like just run out now. So nowadays, I mean, the utilization of PET CT in sarcoma actually has been an ongoing. It's been an ongoing area of study, but ultimately in screening, meaning after someone's been treated and we're just following them. What we want to do. Let me tell you Yechieli's rule of survivorship. Okay. What you want and what people want, I think what people want, is to get the most value with the least potential side effects. The more imaging we do, we can image everyone in this room over and over again, including us, or every one of us, and find really random stuff, and then not know what to do with the information. So in sarcoma in general, the best way to follow is with MRI for any muscle-related thing, and then since sarcomas tend to go to lung, to either follow with a yearly chest X-ray or CT scan. A PET scan won't give us any extra information that will in general be helpful. And sometimes it's a scenario where if we follow people with PET scans, we're doing more, but we're actually, and getting more information, but it's actually going to lead us to less, i.e. or more side effects, because it'll give us information that we don't know what to do, which will prompt us to do other biopsies, which will cause us to have more side effects, which will cause our patients to be really unhappy and then walk out the door.
And PET also has false positives and false negatives. So there are a number of issues regarding a specific type of imaging. And PET scan also requires, well, you do inject radioactivity. So as I understand it, someone can tell me if I'm wrong, it's about 3 times as much radiation exposure as you get just from a CAT scan, from a chest abdomen pelvis CAT scan. And so, I mean, PET, functional image, MRI, or CT, those are the anatomical ways of imaging things, and then you can overlay the PET information on those others. There's really a choice between MRI and CT.
Do we have any questions? There's a box, isn't there?
Yeah, there's a box. Hi, my name's Susan Brown. I am not a karaoke singer. I am not a doctor, but I am a uterine leiomyosarcoma survivor. And thank you. I've channeled my energies to work with the Sarcoma Alliance and happy to be here today and I guess helping to moderate this panel of questions. So as you know, we've been collecting questions for the last 2 days, and I have a few. We're going to start with pretty much the general questions, which will be helpful to everybody in the room, and then I've got additional questions that are pertaining to different sarcomas. So hopefully we can get to everybody's questions. So let's start with, in this age of technology, people refer to the internet to answer medical questions, which is not always the best idea. Can you give us a safe, reliable, up-to-date site for the newest information in sarcoma research?
No. Because the research is ongoing, so by its own nature, it's changing. I mean, if you want to try and read into the literature, yourself, then good old PubMed at least has a number of good articles. They're usually about, I get a feed of different sarcoma articles each week. It's about 100 that come out on any given week, somewhere between 85 and 120. Maybe it should be case reports, they could be more serious studies, but that's kind of the realm that you're talking about. For general information, either ACS, American Cancer Society, has some decent information on the basics of sarcoma, and the website that we've contributed to as part of our professional organization, ASCO, it's called cancer.net, and it's also a fairly reliable source of vetted material. It's appropriate reading age. It's like 8th or 9th grade level for a lot of it. So it's vetted. It's made to be readable, understandable, and I believe there are also some links to things like clinicaltrials.gov and things like that.
So as somebody who went through this in 2012, can you reiterate where not to go? Because I went everywhere where not to go. So, I mean, you just answered where we
It's a
should
big
go.
minefield out there, right?
It is a
I mean,
minefield.
And getting reliable information is hard. Certainly from academic centers, you're going to have a higher degree of vetting and quality of information than you will from Mike's sarcoma site or some other place that's, I don't know, promoting technology or a treatment plan or things like that. I mean, the people who take care of these sorts of, are trying to do the research and are trying to study these things are the folks at the academic centers, and are probably the most reliable resource, more so than, let's say, a company website or even a third party website. But it's very hard. You also want to, there are also Twitter feeds and Facebook pages and things like that, which can, they're kind of scary, aren't they? Right? I mean,
Yeah.
they can be very frightening as well. And it's the squeaky wheel that gets greased. The people who are active posting are the people who are active posting, for better or for worse, right? So it's hard to get a level or evenly fair and balanced version of information apart from websites like that, from more academic sites, I'd say, and just in general.
Absolutely. Yeah. I think one of the key things I tell all of my patients is do not go on the internet. And a lot of the, just kind of starting from the beginning, another site that I recommend is the nccn.org. There's a patient patient guided source on there as well. And that has a lot of information that's obviously also coming out of the academic centers that treat sarcomas. And that's
What is NCCN? It's
nccn.org, and then it'll be the patient. There's a patient and there's a clinician.
portion of the website. Yeah, NCCN is National Comprehensive Cancer
Network.
Center and Network. So the biggest centers, the top 30 or 40 centers, they've actually had to pay in to be part of this effort, but there's also grants that get sent out by NCCN for research, so it's part of the reason for doing this. But these are the group of people who send their physicians to sit on committees to say what the proper treatment should be for diagnosis A, B, C, D, E. And they have guidelines for each of the cancers, sometimes in very great detail, available certainly for physicians, but there's also a patient-specific area, so you can get a sense of whether things are being done right or not.
Yeah, but the most, I have sat on their panels. The most important part of the NCCN guidelines is sarcomas should be treated at a center with multidisciplinary expertise in the management of sarcomas, which means the likelihood that your doctor knows anything about a sarcoma, if you're going to a doctor in the community, a doctor even at a small academic center, approaches zero. So the most important thing is you need to get information from real experts. So that means people who see 10 sarcoma patients a day not 10 sarcoma patients in their entire career.
Thank you, very good point. And at Cedars, they told me to stay off the internet because I needed to focus on my success because there was no reason why I couldn't be successful like everybody in this room.
Yeah.
So a question for everybody is, in your experience treating numerous sarcomas, are there any commonalities that people feel, see, observe when they think they're having a reoccurrence? These aren't trick questions.
I would say for the extremity sarcoma, sometimes you can see nodules that are raised or bumps. They can be red depending on if it's an angiosarcoma, if you look like blood vessels. There's just different things that can be near the site. Oftentimes it's scar tissue, so scar tissue in general. We chase scar tissue a lot. We'll biopsy it sometimes to make sure that there isn't recurrence there, but I would say just in the extremities, it's keeping a close eye on the skin and the area where the surgery was performed and be familiar if anything abnormal pops up. I think it's harder for abdominal structures. It's imaging that we go by majority of the time, but I'll let Dr. Benjamin.
Yeah, I mean, so the majority of the time, there are no symptoms associated with recurrence. But patients, that is human beings, always have symptoms. Every one of us in this room has something that you're young enough, maybe.
Surgery has made me old.
She has tired feet.
So that the major thing, if you're looking at yourself, should I be alarmed with my symptom or not? The first rule is, has it lasted for more than 2 weeks? If it has, is it steadily getting worse, or is it just came up, but it's really the same? Because the characteristic of cancer-related symptoms is that they are progressive. And so the vast majority of symptoms that any of us get will go away in a couple of weeks or less. And if they do persist and they're getting worse, then yeah, if you have a history of cancer, for sure, you should be seeing your oncologist and get it evaluated. The likelihood is it's not related to your cancer, it's related to being alive. But the only way you find that out is with appropriate imaging.
And look how big these tumors get before they even present themselves, right? I mean, it's so the fact that the tumors are gigantic by the time they show up in the first place. You have these 20, 25 centimeter cysts or big retroperitoneal tumors. They're silent, right? Until they're really, really big. So it's not surprising that also the recurrences don't cause a lot of side effects either. That said, I've had various people who say, well, pain might be one, or a cough that doesn't go away, shortness of breath, wheeziness. All those could potentially be signs, but yeah, they would be slowly and gradually worse over time. And I've had the occasional patient who said, I can taste it when my tumors come back. It's something in their taste sense changes.
I have felt my 2 recurrences. Yeah. So that I actually have asked that question because I think it's important for everybody in this room to be cognizant. But the second part of this, is there a diet or exercise that you would recommend to help, keep attuned to a potential reoccurrence? Is there anything we can do to be ahead of or on top of this, or
I guess
I'm trying to prevent reoccurrences?
Yeah, we're going to hear it this afternoon, right?
Yeah.
And the usual talk I give is if there were something new about diet-wise that would help people, well, that's systemic therapy, right? I mean, the problem is all your nutrients go to both the normal cells of the body as well as the tumor. So there are very, very few ways to intervene in that sense. I mean, the models that have shown that, for example, sugar is good for tumors, right? Those are very artificial studies in engineered mice, genetically engineered mice. So you can show it in an extreme case. But for example, if the tumor wants sugar, you can sure as heck bet that it's going to break down something else in order to get it. So I usually tell people not to have crazy changes in their diet. I guess we'll go into that more this afternoon. And try and maintain a healthy lifestyle. If you are getting chemotherapy, that's an extra tax on your body, and you may actually need more calories rather than fewer. It's also complicated by the fact that your taste buds get screwed up by a lot of the drugs we give. So it's a complicated question.
I've heard the sugar as well, but
Yeah.
yeah, I
So
mean,
that-
it's everywhere.
So, yeah, they're all,
Occasional ice cream is okay, right?
And the dessert's on our table.
the sugar myth is just that, it's a myth. What Bob said is exactly correct. The tumor does use sugar, but your body contains more than enough sugar to feed the tumor forever. And it doesn't matter whether you add more or you don't add more, it will find a way of using it. Conversely, eating a lot of sugar doesn't change the rate of growth of the tumors. So just forget the sugar thing.
If I could also add, and it's getting a little bit on a soapbox, all this crap about alkalinized water, pH 9, pH 10, normal pH is, neutral pH is 7, our body's pH is 7.4. So the only place where that might make any difference is if you're a kidney patient on dialysis. The idea is that if you start having a spoonful of baking soda each day, well, your immediate response to having more base, higher pH, is that you actually stop breathing so quickly, and then your kidney starts excreting the extra sodium bicarbonate within 1 to 3 days. Similarly, if you start having, I don't know, a quart of orange juice a day with more acid in it, the first thing your body would do is to breathe a little bit more quickly to make up for the extra acid. And then again, the kidneys excrete the extra acid over a few days. So your body's in a very tight balance that keeps the pH at 7.40. If it goes to 7.41 or 7.39, it makes adjustments to keep it at 7.40. So so all this stuff about alkalinization doesn't matter. The only kidney patients on dialysis, they don't have good control of getting rid of acid by their kidneys. So that's why they actually take a supplement to keep their body alkalinized overall. But otherwise, it's an incredible marketing ploy, and there's absolutely no science behind it. I hear this all the time as well.
Yeah, we only wish that every dollar that has gone into the quackery would come to support valid research.
Good point, thank you. Lemon and water. I mean, why buy the water, right? You like the taste. So easy stuff. Dr. Mackey and Dr. Benjamin, you gave wonderful presentations this morning, but it's an overarching question. Of the new clinical trials in chemo, where are you seeing the most hope and success in sarcoma treatments, meaning which sarcoma? What's moving ahead of our 70 sarcomas the quickest, which may help other sarcomas? Does that make sense? Okay.
That's a tough one. Got me. No, I mean, in as much as we have, if somebody comes up with a drug that treats a certain molecular alteration, molecular change, ALK inhibitor, and you happen to have a ALK altered tumor, an inflammatory myofibroblastic tumor or something, then fantastic, you've got a winner there. I'd say the different classes of drugs we're looking at are metabolic inhibitors, actually do mess up the sugar using or other carbohydrate using properties of tumors, so-called epigenetic drugs, which alter the DNA in a different way in cells, but have not really been shown useful except in very rare circumstances. And then immunotherapy, there's so much being invested in that realm that's still where the richest vein is, because that's where the most money is being spent. It's at whatever it is, $20 billion a year market or something like that. This is how the companies can advertise on TV every night, because they are just treating so many people with lung cancer, bladder melanoma, what have you, with some success at least. But amongst the sarcomas that are responding best to immunotherapy would be what? Undifferentiated pleomorphic sarcoma, angiosarcoma, occasional D. diff chondrosarcoma, maybe a D. diff lipo here and there. What am I missing? ASPS, alveolar Southpart sarcoma. So those are the ones that seem to be responding most frequently of the first generation drugs. And then they've barely scratched the surface. We talk about these drugs being so-called immune checkpoint inhibitors. We've targeted basically 2 of them. And now the research is going to look at the next 20 of them. They're beginning to cull through which ones don't add anything to what exists already and which ones actually do something different, new and different. So there'll be variations on that theme since they seem to be the most financially well supported that we'll see at least in the next couple of years.
Wonderful. Is magnets a therapy that can help the body, or is it quackery? Okay.
There's the very unusual data regarding brain tumors, right? That wearing this cap that provides a magnetic field actually can be helpful for at least some people with gliomas, those most common brain tumors that are very, very aggressive. And there are at least some randomized data to say that it helps. People are actually beginning to investigate this in sarcomas as well, but when it's metastases, you can't really apply a magnetic field to the lungs so easily. So it's a different kettle of fish, I think, and difficult to see how it would be applied. Right? There's not an interventional approach that might involve that. I mean, unless you get lots of MRIs involved. Magnetic fields, I guess.
Anyone else? Okay. Can a biopsy needle spread the cancer? And there's a second part to this question. Can a biopsy miss where a cancer is and give a false outcome? Yeah, well, absolutely. I know that uterine leiomyosarcoma. So.
Yes, and yes, for both. So one of the things that's most important is you don't biopsy the vacuum. So I need to tell my surgeon, I went on this route, this is where it is. So when she comes to cut it out, she's taking that whole route, especially with sarcomas. Other tumors like renal cell, it was overkill, that theory about don't do biopsy, but very, very important. So when you get biopsies locally, which is fine to do, take the time before you go home, get the CD. Just go by, it'll be a film library, you know, one poor human who makes those CDs. Get your CD because everyone needs to see it. And that biopsy CD is very important to see, oh, what was their approach? And then a lot of times we repeat biopsies, and it could be that you're dead on targeted, and for whatever reason, the tumor is kind of encapsulated. And I've had it happen to me where I'm there, it should be in it. But I've learned to take the picture of where that throw is. You kind of saw in my picture, there's the outer canal, and you think you're going to get it. See where that inner one did penetrate and give you the answer. Then you can be even in the silliest situation ever, which is it's a big tumor. And these are the worst. I hate biopsying those 12-centimeter tumors because you'll be in it. You know you're there. You get 4-6 cores, and then when you look at the pathology, it floats. So what did I get you? I got you necrosis. It is not going to give an answer. And I can waste a lot of time. It's dead tissue.
That tissue doesn't tell you anything.
You got to find a different place to go. So you sometimes repeat it and be like trying to give the repeats to someone else. Like obviously I was the wrong hand that day. Maybe you're the right hand that day. And some of them I tell, look, I'm not going to win. Go open and just have someone open, hold it, give them a release.
What's the success rate for core needle biopsy, let's say? How often? I mean, just give a ballpark estimate.
I don't even know. I don't think we calculate the numbers. I know in liver tumor and hepatocellular, they'll say 96%. But again, it's a different thing. With sarcomas, a lot of times people are uncomfortable. They're a little more vascular, so they can bleed longer. And they take you to weird locations. I think Dr. Goel showed the anatomy a lot better. You're running through a lot of stuff to get there sometimes. So I think we have more false negatives with sarcoma biopsies than other tumors because it's a tougher biopsy. It's always, you're not getting the right answer. And then there's a question I think actually one of the patients brought up, are you getting the right spot? So I have 2-3 tumors and like with the liposarcoma, yeah, if you just go into the island of fat, you're gonna get fat. That's not the right place to biopsy. You have to go where you're gonna get the answer. So even before we do a lot of biopsies, we present them a tumor board for the biopsy, like, no, we're gonna go here, this is the part that's growing, that's changing, that's gonna give you the answers. And a lot of times as you go to tertiary centers, we'll repeat the biopsy for not even the reason that they didn't get it, but did they get enough to run the molecular studies? So as the target agents and things get better, we owe you more tissue.
So one big difficult area for biopsy in sarcomas is dedifferentiated liposarcoma. We've actually reviewed our experience, and we miss the diagnosis a third of the time. So it's actually gotten to the point where we now think we're more likely to be right based on imaging than we are by biopsy in that particular diagnosis. It's a diagnosis where you're dealing with a very large, very heterogeneous tumor, most of which will be well-differentiated liposarcoma, and we can determine that just looking at a CAT scan that there's a liposarcoma-like tumor present. The question is part of it undergone a secondary malignant degeneration to become dedifferentiated liposarcoma? And what we found now is that we're better with PET scan in calling D-diff lipo than we are with biopsy. So if we think it's D-diff lipo and the pathologist tells us it's well diff on the biopsy, we say, thank you very much, but we're going to assume it's D-diff and we treat it as such.
It's another good example that arises is bone tumors. Bone tumors, when you biopsy them, actually don't necessarily give you a definitive answer. You have to look at the pathology result in the context of the radiology results. You need the x-rays, you need the CAT scans, MRIs, and look at that in concert with the pathology. Otherwise, you can't make a proper diagnosis. So if you don't have both parts there, as you would have in a multidisciplinary setting, you're potentially missing the boat. So again, it's another good example of where even the biopsy itself isn't necessarily enough.
That's the one time if the doctor who's there with you says, you know what, it's not a good idea for me to biopsy, that's the right thing. I've done it myself. I've seen some tumors and said, look, I understand this is lump, but one, my biopsy is wasting your time. I know a brain surgeon can take the whole thing out, and I'm not having to be biopsying one part. So I've rescheduled patients. Like, you know what, let's get the whole picture before we go after it, because you may not even. And I do that a lot with lung nodules as well, because now the lung surgeons are so great at why do you need biopsy? You're healthy, you're great. We're just going to take the whole thing out.
And then you're home in a day or two.
Right.
So when in doubt, cut it out. Sort of. I heard this said by doctors, I don't think you. Okay, so 2 parts. Does chemo kill all the cancer cells in the body, or does it have some left behind? Part 2 is, what about stem cells to kill the growth on new tissue? Or new tissue, to kill or grow new tissues?
Oh, yeah, right. Yeah, so chemotherapy kills a fraction of tumor cells, and tumors or sarcomas, once they show up, they're probably, I don't know, what is it, 100 billion cells, so 1 followed by 11 zeros. So chemotherapy would have to kill off every cell. That would be pretty remarkable. But even killing off 99.9999% of cells would still leave some behind. This is why surgery still ends up being the curative approach. There's some situations where it's just not tractable. Let's say you've got a metastatic Ewing sarcoma, and then of the pelvis that's hard to remove with that horrible morbidity, and it's metastatic already. Some people can actually still be cured with the combination of chemotherapy and radiation. So in most situations, though, we talk about only a fraction of tumor cells being killed off, and that determines how well the tumors shrink oftentimes. That was the first part of the question.
And then just following up on that, so that's the reason why the likelihood of cure with chemotherapy is higher when there are fewer cells present. And that's the whole strategy behind using chemotherapy early in the course of the disease when you know that the surgeon will remove the bulk of the tumor, and you're then dealing with trying to kill a million cells
10 billion.
instead of 10 billion, right?
It really is a numbers game. And the question on stem cells, cancers are derived from, they grow from some sort of stem cell. So the place where we use stem cells to help people in treatment is in the setting of what's called bone marrow transplantation or stem cell replacement therapy. You give people high doses of chemotherapy to wipe out as many cells as you can, and then you give the rescue of the stem cells. But actually what we're trying to do is, amongst these tumor cells, is kill off those stem cells because we know the other ones aren't going to cause as many problems. We've been trying to do that for years, and we've reached a plateau, at least in a number of diagnoses, in terms of how many stem cells we're able to kill off. If we can find drugs that better target the sarcoma stem cell, then we'll be making a lot of progress. The problem is they don't divide as quickly, and they tend to have mechanisms to remain resistant to chemotherapy that even their progeny may not have.
Wonderful questions, guys. Regarding clinical trials and research, given the atrocities in research found in the studies with the Tuscany Airmen and many others, do you find there are certain racial or ethnic groups that are less inclined or reluctant to participate in a clinical research?
Absolutely. I mean, just how suspicious are you that you're going to be quote a guinea pig, right? What is the trust factor there? Knowing these stories, these events that occur to so many people, it leads to distrust in general, right? So we'll see. People don't want to participate in trials for a number of reasons. That certainly would be one of the factors if they're familiar with what's happened with those sorts of studies, with the concern that could that be me too.
To that point, a lot of times I tell patients, a lot of how we consent someone for a clinical trial has changed. So you don't consent for a clinical trial the minute I'm going to give you the dose of medication. So you take that home. What I encourage people to do is, one, don't go to your doctor's appointment alone. Bring a stenographer. Bring the person who drives the most nuts, who's going to do the most research and read these things. And that's who you need in the corner. And let them participate, because if you're always the one handling the stress and the information, the decisions are that much more difficult. And we all have family all over the place, so a lot of us will just say, hey, put them on the phone. It's easier for me to do this once in person than to have everybody translate the information. And when you get those pieces of paper, take the time to read it. That's why you get the week before you sign on, in 2 weeks or whatever. They are actually really, really nicely written, and it has every detail of every ounce of the trial. So I tell people, before you say no, at least take it home and read it, and then tell me no. It's totally cool, but just a different approach.
Yeah, and I think so the question is, are some groups less likely to participate? And
Some
I
ethnic
agree,
or-
right. I think the answer is yes. No question. But I've found that on the individual discussions with patients, I have not found that any ethnic group will not participate. There may be a slightly higher likelihood of participation. There may also be a slightly higher likelihood of even seeking medical attention in some ethnic groups than others. But the ones who make it through those filters, who come to see specialists in our group, I don't think we have a major difference in participation rate among the ethnic groups.
I'd say the biggest barrier, at least working, in what's more of a community setting, at least these past few years, has been more logistics as much as anything. I think that's the biggest limiting factor. You have to make a bunch of extra visits to the hospital, and you're already driving an hour and a half each way. It's so disruptive that it makes it very difficult to participate. And in as much as we can keep this, it's important for us who are writing those trials to, the KISS principle, keep it simple, stupid. You want to not impose a lot of extra burden on the people you're trying to treat. And so it's, I'd say as much as anything, logistical issues are even surmount any kind of ethnic variations you might see.
It all takes a lot of time for all of us. Emotionally, that's one factor, and then the physical factor of it. So we are new to the sarcoma world and have learned a lot through research and this weekend. Thank you. We have been alarmed by the high rate of recurrence and limited understanding of why these cancers occur. It is the million-dollar question. You have many years of practice and have seen many patients. You're all scientists, but off the record, my question is, if you were diagnosed with sarcoma and had no evidence of disease, but knew you had a chance of getting the disease again, what would you do different in your life to reduce the chance of reoccurrence?
Do over. How would you live your life over?
Yeah. It's all off the record, by the way.
Yeah.
Oh, stop this.
You're the same honor off the record. I mean, this is not a politically charged question. The true answer to what would you do differently in terms of your life is, one, realize its value. Realize how important it is that you are here and alive today, because you may not be here and alive tomorrow. And most people tend to forget about that. Those of us who deal with patients who unfortunately die much too frequently get the reinforcement as to how precious life is. And so the one thing I would tell you to do differently is, boy, appreciate the fact you're alive and take advantage of it and make the most of it. In terms of what you can do to modify whether your cancer is going to come back, the answer is nothing. So don't try. But the other thing is, you do have a lifelong risk of recurrence of cancer. So you need to continue to be followed forever. I have patients who've relapsed at 30 years. You don't stop coming to the doctor. Just because the likelihood is you're fine, I buy that every minute. Take one day a year to make sure you get checked, to make sure you really are fine. Because if you're not being checked, then what will happen is you will discover you're not fine when it's too late to do something about it. And then you've lost. So yes, you've got to keep track of it. Cancer is inconvenient. That quotation comes from one of my former patients, who is one of our advanced practice nurses, who was treated for Ewing sarcoma 30-some years ago. But the point is, yes, it's inconvenient, but you didn't choose to get it. You got to deal with it while it's there. So the fact that you're alive and free of disease at your checkup today, wonderful. Just don't forget to come next year.
If there's, there aren't good studies to say, how do I reduce my risk of cancer overall? If there's anything that helps in terms of a preventative sense, it's, actually, and as much as we talk about diet not being helpful in terms of, do something you can do once you've been diagnosed with cancer, metastatic cancer, is there something you could do just proactively lifelong? And, there's some, based on some epidemiological data, for example, the good old American diet is probably bad in terms of your risk for colon cancer. So the more that we add, fruits and vegetables and replace meat with those things, or at least decrease our intake of red meat, that is supposedly helpful. And I would say also any kind of activity for some reason, number one, it's a stress reliever, and number two, there are actually some data that it can certainly decreases overall mortality, some portion of which is cancer related. So I think we'll hear more about it this afternoon in terms of the dietary discussions and so forth. But it's sort of a different context as a preventative aspect as opposed to a therapeutic one.
Right, I think I hear a lot on leiomyosarcoma sites that people stop getting scans after 5 years because we hear the mantra of the breast cancer survivors and its reoccurrence. So thank you for reinforcing that fact with everybody.
Yeah, and most of these tumors are sporadic. They just happen spontaneously. They're good data. There's a really nice work from Johns Hopkins indicating that seems to be the case, except for obvious exposure-related cancers, be they lung cancer from smoking or melanoma from sun exposure, things like that. Even that's not such a great link. What's amazing now is we can sequence the DNA in an individual cell, and they've now we've done this in bone marrow biopsies on a number of patients. We've done this even in young people with cancer. Young person with cancer, you take out their tumor, there's some normal cells nearby. Take the normal cells, separate them all out, take maybe 2,000 or 3,000 of them. Take the DNA from each of those cells in a 15-year-old, sequence all of them. Every cell in that person has mutations in it. And the mutations are not the same. They're different from one cell to the next, to the next, to the next. So what's happening is that we're not perfect machines. Our DNA does not reproduce itself perfectly. And so this is why cancer most commonly is a phenomenon after age 50, when you've accumulated a number of mutations. It's nothing you do, it's just the biological clock that we all have. Some people have a faster mutation clock than others that predisposes them to certain cancers, BRCA1, BRCA2, good examples. Certainly the familial colon cancer syndromes as well. But for all of us in the population, it's happening every day. It's kind of scary to see it. But we now have molecular documentation that this actually happens.
So I think our takeaway is see a sarcoma specialist, get your scans regularly, don't ignore your symptoms, don't ignore your treatment, and just be cognizant and live in the moment and live your best life. And with that, we're out of time for questions. I apologize that we didn't get to everybody's questions, but we hope this panel has been helpful for everyone. So thank you.
So our next speaker is Dr. Soares. He is a geriatric and palliative care expert. So that means he did